Good evening, everyone. My name is Arthur Vaughn. I'm the chair of health and wellness for the 100 Black Men of North Metro Atlanta. Today is the next in our virtual health and wellness series, and we're going to discuss heart health. Our guest speaker is my favorite cardiologist. Y'all don't tell Winston Gandy that. I'll be in a lot of trouble. Dr. Alanna Morris. Dr. Morris received her undergraduate degree in biology from Xavier University of Louisiana and her medical degree from the Harvard Medical School. She's an assistant professor of medicine in the Division of Cardiology at Emory University School of Medicine. Her clinical time is spent as the director of heart failure services at the Atlanta VA Medical Center and as a faculty for Emory Center for Heart Failure Therapy and Transplantation. On a personal note, when I was in the hospital in 2019, or even after when I went through rejection twice, I always get excited when what I called my team came around the corner. One day I was in for severe meningitis and the pain was excruciating. And when I saw Dr. Morris and the team come around the corner, I knew everything was going to be okay. And because of them, I'm here with you today. That's enough for me. I am now going to turn it over to Dr. Morris. I'll be monitoring the chat, so feel free to put questions in the chat, but we also may open it up for a dialogue. Without any further ado, I'd like to turn it over to Dr. Alanna Morris.
Thank you so much, Arthur, and thank you for having me. I do hope we will have time at the end to talk, and I would love to be able to answer all of your questions, as many questions as we can. So let me share my screen. So are y'all seeing my slides? So I told Arthur that I thought we were talking about that primarily we would be talking about heart disease in Black men, but I do have slides that are not necessarily gender or sex specific. So if there are some ladies in the audience, please feel free to ask questions as well. I'm sure many of you are married to and or know Black women, so I expect you to take this information home. Okay, so of course, we've been talking about the health of Black Americans, I think more in 2020, perhaps than ever before. And a lot of that conversation was really triggered by COVID-19 because of the realization that Black Americans were dying from COVID-19 at rates that were significantly higher than other race ethnic groups. This is data that's constantly being updated showing that Black Americans were dying at about 2.5 times the rate of white Americans. And again, this data is somewhat limited by how states are reporting, and of course, whether or not we are actually getting accurate data at any time. So this was really the first time as a country that sort of everybody was really talking about the concept of health disparities and what the underlying causes of health disparities are. But there are those of us who have really been talking about health disparities for a long time. This is not new. COVID-19, again, didn't cause health disparities. They just uncovered, or COVID uncovered health disparities and really brought this into mainstream talk for the first time. This has been something that is near and dear to my heart and has been the reason why Arthur doesn't always see me in clinic, because I spend the majority of my time doing research, trying to understand health disparities and trying to understand why heart disease, and particularly heart failure, affects Black men and women at rates that are significantly higher than other race ethnic groups. So to get us all on the same page, fact. Heart disease is the leading cause of death for women and men, regardless of race and ethnicity. So we talk a lot about COVID-19, but in fact, your risk of dying from heart disease is still significantly higher than it is of dying from most other cancers, COVID-19, stroke, really everything else that's on the list. And when you look at differences in life expectancy, so we know that Black men have the lowest life expectancy of all groups in the US. The difference is mostly related to the higher rates of heart disease in Black men. So what this figure is showing you is a couple of the things. Here's life expectancy as of data from 2015, with Black men having a life expectancy of about 72 years as compared to 76 years for white men, 79 years for Hispanic men or Latinx men. And what this graph is showing you is the different conditions that sort of make up that gap. So the blue bars are the conditions that cause a disadvantage, with heart disease causing most of the disadvantage for Black men, followed by homicide, then cancer, then cerebrovascular disease or stroke, and then Parkinson's, lower respiratory disease, and liver disease, and suicide. If we look at women, what you can see is a similar graph. So again, here you can see Hispanic women have the longest life expectancy, about 84 years, followed by white women, 81 years, and Black women, about 78 years. And again, you see the same thing, that if you look at the disadvantage, heart disease is the #1 cause, right? If we could get rid of heart disease, we could make the most progress in terms of bringing this number, this 78 years, closer to that 81 years for white women, followed by cancer, diabetes, perinatal conditions, and cerebrovascular disease or stroke. If you want to sort of talk about this another way, one of the things that we talk about in society, or particularly if you talk to cardiologists, they'll say, well, rates of heart disease are coming down, that we're making a lot of progress, that people are dying from heart attack, they're dying from stroke, they're overall dying from heart disease a lot less than they were 10, 20, 30 years ago. And in fact, that's true. And what this slide is showing you is exactly that. So what you can see here is whites, Blacks, Hispanics, non-Hispanic Indians, and Alaskan Natives, and then Asian and Pacific Islanders. And for each of these groups, this is sort of the rates of death from cardiovascular disease over the last 10 years. And you can see that all of these red lines are coming down. So that's the good news, that all of these groups are dying from cardiovascular disease less than they were 10 years ago. Here's the bad news for us as Black Americans. Our rate of death from heart disease in 2017 is still higher than it was in 2007 when we started to make progress for white people, right? So here we are way up here. And so the progress that we've made is still significantly worse than every other race ethnic group. So we still have a lot of work to do. If you look at death rates for stroke, you see the exact same type of statistic, or the same type of figure. So again, you can see that death rates from stroke have come down for all groups. Here's us, non-Hispanic Black Americans, in this second bar. And so again, you can see that our rates of death from stroke have come down. Unfortunately, they started to go back up a little bit over the last couple of years. But the progress that we've made over the last 10 years still doesn't bring us anywhere close to even where our white counterparts, Hispanics, or American Indians and Alaska Natives, or Asian Pacific Islanders were even before they started to make progress 10 years ago. So we have a lot of work to do to get our health conditions on the same bar as everyone else. Of course, I said I'm a heart failure cardiologist, so of course I spend most of my time thinking about heart failure. Same type of graph, or if you look at death from heart failure, that if you look at the progress that we've made in terms of reducing death from heart failure for everyone else, the numbers are coming down. But again, if you look at Black people, here we are at the top, that our rate of death from heart disease is much worse than every other group. And here's Hispanics way, way, way down at the bottom. So again, we have a lot of work to do. So when we talk about heart disease, it's sort of a broad term that we use to describe a range of diseases that affect your heart. And that can include coronary artery disease, which we sometimes use to describe a heart attack. There are some people who have blockages in their heart arteries. So you can have coronary artery disease and get a stent, but not necessarily have had a heart attack. Again, I take care of people who have congestive heart failure. Some people have heart failure from having had a prior heart attack. In fact, in Black Americans, it's much more common to have heart failure if you have not had a prior heart attack. We tend to develop heart failure because of hypertension, most commonly, what we call non-ischemic heart failure. Arrhythmias fall under the broad term of heart disease, so people who have abnormal heart rhythms. Sometimes those abnormal heart rhythms can be benign, sometimes they can be fatal. They can be the type of thing that can make you just drop dead in the airport or make you die in your sleep. Some people can get infections of their heart. There can also be diseases of the heart valves that can require surgery, or a new heart valve need to be replaced. And we also talk about cardiovascular disease. So this is talking about the diseases of the heart and the blood vessels, right? Because the heart can't work alone. It really has to work in concert with the blood vessels. And this is particularly important for Black Americans because of the risk of hypertension. I know you guys are going to have another talk about hypertension, I heard, in a couple months. So hopefully you'll take all of this in and then come back to and have it repeated to you in a few months. But this is important because cardiovascular disease is talking about any of the above, but also your risk of stroke, as well as your risk of circulatory disorders like peripheral arterial disease. We know that when we talk about amputations in our community, they're much, much higher than they are in other groups. I'm sure many of you know grandmothers, sisters and brothers who may have had their toes amputated for diabetes or other things, and that's not always done based on good evidence. And so all of this falls under the term cardiovascular disease, and it's really important for us to know what all of this means and know these terms. So again, I've shown you this data, but Black Americans have higher rates of heart disease, whether you look at heart disease alone or cardiovascular disease combined. And this is just some of this data. The other thing that's important to know is that we tend to think of heart disease as a man's disease, and that's not true. For my Black women who are on the call today, or for my Black men who are going to go home and talk to Black women, it's important for Black women to know that we are affected by heart disease, in some cases more so than white men. When you look at the rates of heart disease amongst young Americans, people below the age of 50, many times African American women have rates of heart disease that are actually higher than white men, higher than Asian men, higher than Hispanic women, or higher than Hispanic men. That is particularly true for heart failure. So heart disease is not just a man's disease, and it's very important for Black women to understand that. Again, if you look at rates of first heart attack, you can really look at any age group, 35 to 44, 45 to 54, 55 to 64, 65 to 74. And within every single age category, if you look at Black men have the highest rate of having first heart attack compared to every other race ethnic group. So y'all are at highest risk, okay? If you look at the rate of first stroke, again, we see the same type of phenomenon where if you look at the risk of stroke over the course of a year, if you look at the number of risk factors, so this is sort of one of the scores that we use to look at the number of risk factors. If you have high blood pressure, diabetes, you're overweight, you're physically inactive, you've had a prior stroke, the more of those risk factors you have, the higher your risk of having your first stroke. But what this graph is showing you is it doesn't matter if you only have one risk factor or if you have 9 risk factors. If you're Black, your risk of having a first stroke is higher regardless of how many risk factors you have. Same thing here for heart failure. This is a study that's quoted a lot, where this was a study that enrolled young people, young Black and white people primarily, who didn't have any risk factors for heart disease at the time they enrolled in this study. And then we followed them over 20 years. So at the time they enrolled, most of these people were between the ages of like 18 and 30. They were very young. And over that 20-year follow-up, the risk of developing heart failure was over 20 times higher in the Black men and women as compared to the white people. In fact, there was only one white person in the study who developed heart failure. And high blood pressure was the single most common risk factor for developing heart failure in this cohort of Americans. Again, very, very young Americans. So I've sort of shown it to you in a number of different ways, but I know you guys know this, but it's just important for us to be on the same page. Black Americans have a higher risk for heart disease and are more likely to die once heart disease is present. And the question is really, why? This is a big part of the research that I do. We've published on this a lot. This is one of the papers that we published last year. looking at this from the perspective of congestive heart failure, but in a lot of ways, this really applies to heart failure, it applies to stroke, it applies to heart attack, because the risk factors for all of these conditions are very similar. At the core, hypertension, high blood pressure is really the single risk factor that puts us at highest risk. When we develop high blood pressure, and we tend to develop high blood pressure earlier, and we have high blood pressure that is more difficult to control, that's sort of the thing that just sets it off and really gets our heart in a place that really makes all of this more difficult to control. And there's a lot of different reasons why we have high blood pressure that is more difficult to control. In addition to the high blood pressure, we have other risk factors like obesity, diabetes. We tend to be more physically inactive, and that actually contributes to making our high blood pressure more difficult to control. I know it's difficult to talk about genetics, but there are some genetic factors that are present in African Americans that are important for us to talk about and be aware of that do increase our risk for kidney disease, heart failure. They're not as common as some of these other risk factors, but they're still important for us to be aware of. And of course, in the last couple of years, we've always known this, but now I think as a country, we're talking about the importance of things like neighborhood, our environments, our limited access to healthy foods, and of course, bias within the healthcare system, insurance access. And we'll come back to some of that and how all of these different factors make it more difficult for us to take care of our health as Black Americans. So a number of years ago, the American Heart Association put out this tool called Life's Simple 7. And they really said, regardless of who you are as an American, whether you're white, Black, Hispanic, man, woman, doesn't matter. If you do these 7 things, you can reduce your risk for heart disease. If you control your cholesterol, eat better, lose weight, get active, manage your blood pressure, reduce your blood sugar, and stop smoking, you can really reduce, if not eliminate, your risk for heart disease. So I remix this, and I think that if I were going to put this in order for Black man or really Black people, this is the order that I would put it in. The number one thing I think is important for a Black person, or certainly a Black man, is to manage blood pressure. Number 2 is to lose weight. Number 3 is eat better. Number 4, get active. Number 5, reduce your blood sugar. Number 6, control your cholesterol. And number 7, stop smoking. So we'll talk about each of those. Number 1, manage blood pressure. I cannot emphasize this enough. High blood pressure is the number 1 risk factor that kills our community. Again, the risk for heart disease, stroke, heart failure, cardiovascular disease, it really comes down to this risk of high blood pressure and the difficulty getting our blood pressure under control. Many of you who hopefully been to the doctor in the last couple of years are aware that the blood pressure guidelines changed a couple of years ago. So it used to be that high blood pressure was 140/90. We got more strict as a community, and we said that actually now anything above 130/80 is considered high blood pressure. So what that means for us as Black people is that now even more of us have high blood pressure, okay? So by the old standard, about 42% of Black Americans had high blood pressure. Now by this new, more strict guideline, almost 60% of Black Americans have high blood pressure, okay? So that's a lot, right? That's 60% of Black people are hypertensive by these new guidelines. So what can we do about this? Again, you have to, number 1, know what the goal is, right? You have to know what a normal blood pressure is. And I can remember as a fellow being in clinic at Grady, and I was so angry at one of my patients. And I was like, you have to know what the blood pressure is. And he was looking at me with this like deer in headlights, you know, sort of thing. And I said, well, actually, do you know what your blood pressure is supposed to be? And he was like, no. And I had to check myself as his doctor because I realized that I had not educated him, right, in terms of what his blood pressure goal was. So first thing is know that the goal is that your blood pressure should always be below 130 on the top and below 80 on the bottom. No, 140 is not the goal anymore. 150 is definitely not the goal. 160 is definitely not the goal, okay? The other thing we have to understand is that most Black adults require at least 2 to 3 blood pressure medications to achieve control. And so when you go to your doctor and they keep adding blood pressure medications, they're not doing that because they don't like you. They're doing that because they do like you and because they love you, because they really want to try to get you to goal. And if they keep adding medicines and that number is still not below 130/80, something's not right. We need to figure out why we can't get your blood pressure under control. Because remember that if your blood pressure isn't under control over time, that increases your risk for heart attack, heart failure, stroke, kidney disease, dialysis, dementia, and all of these bad things that I know none of you want. There are certainly lifestyle choices that also make it easier or harder to control your blood pressure. So your diet, which I've heard that you guys are going to talk about, the more salt you eat, the more your blood pressure is going to go up. Conversely, the more you can lower the amount of sodium in your diet, the easier it's going to be to control your blood pressure. If you're overweight, that's going to drive your blood pressure up. If you can lose weight, that's going to make it easier to control your blood pressure. Things like sleep apnea make it more difficult to control your blood pressure. How to get to goal. The first thing I tell people is buy a blood pressure cuff if you can afford it. When I used to work at the VA, we could give everybody a blood pressure cuff and it was amazing. Unfortunately, not all insurance companies will allow us to do this. It would be fantastic if we could, but if you can afford it, just buy your own. You can get one at any retail store for $30 or $40. And it's great to have one at home to monitor your own blood pressure. Take your blood pressure medicines and see what your blood pressure is 20 to 30 minutes after you're taking your blood pressure. Again, eat a low sodium diet. Exercising regularly brings your blood pressure down. Avoid caffeine, avoid drinking excessive amounts of alcohol. I have a lot of male patients who like these energy drinks. Remember that a lot of those energy drinks have a lot of caffeine in them. And some of these energy drinks have a lot of other strange supplements in them that I've seen cause really awful things like heart attacks and other kidney failure. So you have to be really careful about some of these over-the-counter supplements. We don't always know what's in these things. And then trying to decrease stress. We're all at very, very high stress levels. But as much as you can, really trying to decrease the amount of stress that you have or learning to control it. Let's talk about losing weight. This is very, very difficult for all of us. Losing weight is hard. Again, this is some data looking at us as Black Americans compared to other groups. Here's Black men in these blue bars as compared to white men, Asian men, Hispanic men. We're up there. Here's Black women, much more overweight than white women or even Hispanic women or Asian women. When you go to your doctor, they should tell you what's your body mass index or BMI. A normal's less than 25. Overweight is between 25 and 30, and obese is anything above 30. So you can Google BMI calculator and you can do this for yourself. All you need to know is your weight in pounds and your height, and you can tell yourself what your BMI is. And you really want to try to get it as close to normal as you can, because as your BMI goes up, you increase your risk for heart disease, high blood pressure, diabetes, and even certain types of cancer. Eat better. Right? Our diet is linked to all of these things. So if your diet is terrible, you're going to become more overweight. Your blood pressure is going to go up. You're going to increase your risk for diabetes. Inactive men really only need to eat about 2,000 to 2,400 calories a day to maintain a healthy weight. If you're trying to lose weight, you need to understand that there's about 3,500 calories in a pound. So if you want to lose a pound per week, you have to eat 500 calories less per day. One of the things that people will do sometimes is say, okay, I'm going to go to the gym and I'm going to work out, and that's how I'm going to lose weight. And the unfortunate reality is it's very easy to out-consume any activity regimen. Most of us go to the gym and get on the elliptical or, sort of work out for 30 to 45 minutes. And if you're lucky, maybe you burn 300 to 400 calories. But if you turn right around and go to, Panera or something and eat, this is a Frontega chicken panini, that's 400 calories right there. That was your whole workout, half of a sandwich. So the best way to lose weight is to really pay attention to what you're eating. And the AHA sort of put out these guidelines. One of the best ways to look at this is to track what you eat, to know how many calories are in every single thing that you put in your mouth every single day. That's one of the best ways to really get a sense of how many calories you're consuming. For those of you who do this, you will be surprised. And one of the things that we see for men in particular is that men tend to pay less attention to this because you guys have testosterone. You have a lot more muscle mass than women do. And so men can get away with consuming a lot more calories before they start to really pack on a lot of pounds. Men also tend to consume a lot more salt than women do, again, because because you have more muscle mass, your bodies tend to be more forgiving naturally, but that doesn't mean it's healthy. That doesn't make it right. So you really want to try to pay attention to how you're eating and what you're eating to really optimize your heart health. Get active, exercise. The American Heart Association recommends that we should all get at least 150 minutes of moderate aerobic activity per week, or 75 minutes of vigorous aerobic activity every week. You should also strength train. Everybody should strength train, men and women, at least 2 major muscle groups at least 2 times a week. So if you're doing moderate activity, 30 minutes a day, 5 days a week. So things like brisk walking, swimming, mowing the lawn. If you're more vigorously active, if you're doing things like running, step aerobics, spinning, you don't have to do it for as long, but you do want to try to do it 5 days a week, okay? And the more active you are, again, the more you reduce that blood pressure, the more you keep your weight down, the more you increase your bone health and your muscle mass. And this is just good for all of us in terms of our mental health. Reducing blood sugar. Diabetes, we know, is extremely common in Black people. Again, here's Black men. About 14% of us have diabetes, much higher than Hispanic men or white men. Here's Black women, about 15% of Black women, again, higher than Hispanic women or white women. So diabetes is very common in our community. Risk factors for having diabetes: getting older, being more overweight or obese. If you have a strong family history of diabetes, you are more likely to get diabetes. I mentioned that it's important to know, that women who have had diabetes during a pregnancy, what we call gestational diabetes, if your wife or your sister or your mother had diabetes during a pregnancy, they are at higher risk of developing diabetes later in life. Being more physically inactive puts you at higher risk for developing diabetes. And again, just unfortunately being Black or Hispanic or Native American puts you at higher risk for developing diabetes. But not all hope is lost. Again, losing some of your body weight, even 5% of your body weight, can actually reduce your risk of developing diabetes. So trying to exercise, eat right, and keeping that body weight down can really reduce your risk for developing diabetes. Controlling your cholesterol. This is actually one place where we tend to do better than other groups. So I think this is probably the first slide that I've shown you where Black people are better. So here's the prevalence of high cholesterol in Black men and women compared to whites and Hispanics, and our bars are lower. So yay, we're actually a little bit better off, and in some cases our cholesterol tends to be a little bit better, but you always want to keep your cholesterol below 200 to reduce your risk for developing heart disease. So this is a place where we actually maybe have a slight advantage. And then finally, stop smoking. So this is cigarettes, cigars, Black and Milds. Yes, all of that falls under this category. And I always tell people smoking is just the worst thing you can do for your health because it's absolutely unnecessary. This is just a preventable cause of heart disease, cancer, everything. There's just no reason. And again, smoking is absolutely a risk factor for heart disease in addition to cancer and all kinds of other badness. So just don't do it. And the risk of, or the sort of frequency of smoking is much more common in Black men as compared to Black women who tend to smoke relatively infrequently. I'm going to add one more thing. Again, this is not from the American Heart Association. This is from Dr. Morris. So if I'm going to add a life simple 8 for the Black man or just for Black people, it's know your history and your rights. Okay. So I mentioned that, there are other things that are specific to our community, right, that increase our risk for heart disease. And it's important for us to be aware of some of those things, including our neighborhoods, our environment, our limited access sometimes to healthy foods. There aren't always as many gyms and places for us to exercise in our neighborhoods as a result of structural racism. And I think we have always been aware of this. And of course, the healthcare system and policies. Insurance access has always been something that has been talked about in terms of being able to access doctors and good nurses. However, there's now more data showing that even when we go to the doctor, that we're not treated the same. And we have to be aware of that. You have to be aware of what your rights are as a patient. And if you're not being treated fairly, what to do. Some of the work that I've been doing at Emory for the last couple of years is looking at how living in a food desert, for example, affects my patients with heart failure's risk of being hospitalized for heart failure. And we've been able to show that if you live in a food desert, a place that you don't have access to healthy foods, that absolutely increases your risk for being hospitalized with heart failure. And it's not a surprise that, the vast majority of people who live in a food desert are African Americans. That's by design. There's been a lot of interest recently in bias and workplace. We know, for example, that, the kind of job that you have influences very much the type of healthcare insurance that you have. It's not necessarily a surprise. This is one study that actually looked at sending resumes. It was the same resume, but what they did was they took these resumes, and they put more white sounding names like Emily, Todd, Allison on those resumes. And then they put more characteristically African American sounding names like Aisha, Tremaine, Tyrone on those resumes. So again, the resumes are the same, but the names were different. And they sent them to different employers. And there was about a 50% callback difference in for the resumes, and they attributed that callback difference just to the names, right? So, I mean, the lower rate of employment in our community is related to bias, right? Is related to implicit bias. And of course, if we're less likely to be hired, we're less likely to be able to access the healthcare system, less likely to be able to see good physicians and nurses in the first place. But even when we are able to access the healthcare system, what has been shown in different studies where people have used real world patients and healthcare providers is that there is bias in the healthcare system. This was one study that looked at a number of different studies and found that over 90% of studies using real world patients showed that healthcare providers do show bias based on race and skin tone. So it's important for us to be aware of that as Black patients. So when you go to the doctor, you need to be armed, right? Like you need to know your family history. Do you have a strong family history of heart attack, kidney disease? Know your personal history. What medicines are you on? Have you had any recent hospitalizations? And know your rights as a patient. I always tell patients, if you are seeing a doctor and you feel like your doctor's not listening to you and you're telling them that something's not right and they're poo-pooing you, and find someone else. There are doctors who will listen to you. There are doctors who will not, sort of dismiss you. You know your body better than anyone else. And so if you feel strongly that something is not right with you and the physician that you're seeing is not listening to you, keep moving until you find a doctor who will listen to you, because we do exist and we are out there. Okay. I love this podcast. David Williams, for those of you who aren't familiar with him, is the chair of the Department of Social and Behavioral Sciences at the Harvard School of Public Health. And he was interviewed by Ezra Klein on this podcast almost a year ago now, at the beginning of the coronavirus pandemic. But this podcast was really about really why coronavirus was so deadly for us, related to racism, stress, and the chronic effects of those in our community, and how that really just set us up for poor health in general. And it's just such an instructional podcast if any of you are interested in this. So I'll stop there. But Black Americans, again, have the highest risk for heart disease compared to other race ethnic groups. If you can do one thing and take one thing away from what I've said today, it's really that high blood pressure or hypertension really conveys the largest risk for heart disease or cardiovascular disease in our community. But there are multiple ways to decrease your risk by focusing on lifestyle improvements. And if any of you want to get in touch with me, this is my email and this is my Twitter, and I will stop there.
All right, all right. Thank you so much, Dr. Morris. We truly appreciate the information you shared. What I want everybody, but I want us to get our questions answered. So go ahead, if you have a question, put it in the chat. I see a couple there already, but I'm going to start with one. What does coronavirus do to someone's heart?
I shouldn't have taken my slides down because I had a slide on that because I had a feeling someone would ask me that. Actually, Arthur warned me. So coronavirus does a number of different things to a number of different organ systems. When coronavirus obviously first came into our awareness, we were really worried about the effect on the lungs. But the receptor that coronavirus uses to infect the lungs, that receptor exists in multiple different organ systems. That receptor is found in the heart. It's found on the blood vessels that line the heart, the major blood vessels like the aorta. It's found in the kidneys. It's found in the intestines. It's really found throughout the body. And so what we realize now is that coronavirus can infect all of those organ systems. The other thing that we sort of weren't aware of before, because we were sort of looking at data from China, Italy, all these places, and obviously the population in the US is very different. Our population is not as healthy as those populations. We have much higher rates of high blood pressure, kidney disease, obesity, and having those illnesses puts you at higher risk for severe coronavirus infection. So when Corona sort of first came out, we were all saying, oh, if you have lung disease, like severe lung disease, that was going to put you at higher risk for having severe coronavirus infection. And that's true. The thing is, hypertension or high blood pressure, for example, is much more common in the population than is having severe lung disease. Obesity is much more common in our population in the US than is severe lung disease. And so what we learned when coronavirus was sweeping through our country last year was that it was actually people with these really common conditions like high blood pressure and obesity and diabetes that were getting the severe infection. And that was not as clear in China and Italy and these other places. What was also unique to what was going on in the US is that we didn't do what we needed to do to control the pandemic, just period, point blank. So in terms of the effect of coronavirus on the heart, it can do a number of different things. It causes this severe inflammatory reaction. So the virus itself can get in and directly infect the cells of the heart and cause what we call a myocarditis. So it can call that sort of a fancy term for inflammation in the heart muscle. And you guys have sort of heard about these MRI studies where we can do an MRI on the heart and detect inflammation in the heart muscle weeks to months after people have been infected, even in people who didn't even know they were infected. There have been some really high profile cases of, some young athletes who have passed out on the court, who had relatively silent infections because of the residual damage that was there. Some of that is related to the arrhythmias. So we talked about early in the talk about these abnormal heart rhythms or arrhythmias that can happen. When the heart is inflamed, it has a propensity to go into an abnormal heart rhythm. And when the heart is not beating normally, that's the thing that can cause you to just drop dead. So when you hear about these people with coronavirus infection just dying suddenly, it's probably because of one of two things. It's because their heart goes into an abnormal rhythm, an arrhythmia that just makes them drop dead all of a sudden, or it's because they have what appears to be a heart attack. The inflammation from the virus causes sort of a rupture of a plaque in one of the heart arteries that causes what is something like a heart attack, but it's probably caused by the inflammation from the virus itself, not necessarily a typical heart attack. The other thing that this virus can do is cause blood clots. It can cause blood clots in the veins in the legs that can travel up to the heart, up to the lungs, and cause people, again, to sort of drop dead all of a sudden. So we weren't expecting all of these different effects of coronavirus when, the data was initially coming from China. So this virus is really, really smart, really, really sort of effective as a killing machine. And it's been able to do things that as a scientific and medical community, I don't think that we were prepared for. And in part of that is because, again, we were basing some of our knowledge on what we saw initially in China. But part of the difference is China was able to get the virus under control relatively quickly, whereas in this country, it just continued to spread and spread and spread and spread and spread.
Wow. Thank you, Dr. Morris. That was a lot of great information. One of the questions we have is, can you put your contact information, that Twitter account and such, back up for folks?
Yes.
And while you're doing that, we have a question. Why is the stroke rate starting to increase for Blacks?
So what's interesting is high blood pressure is actually not being as well controlled as it was. Most cardiovascular diseases are going in the wrong direction. And part of the reason for that is because as a population, we're becoming less healthy. If you look at most of the public health messaging in the 70s, 80s, it was sort of focused on two main things. Stop smoking, and we've done a pretty good job of that, and control your cholesterol, and we've done a pretty good job of that too. The other thing we've done a really good job of, for the most part, is that when people have chest pain and they come into the emergency room complaining of chest pain, most of the time you get an evaluation for that pretty rapidly. What we're not doing a good job of as a country is controlling our weight. We're becoming more obese, more overweight and obese for a variety of reasons. And so as our weight has gone up as a country, as we become more overweight, more obese, more physically inactive, our blood pressure has gone up, our rates of diabetes have gone up. And that has actually driven up the rates of high blood pressure, stroke, heart failure. And so, in fact, a lot of the rates of heart disease, stroke, and heart failure in our communities now are being driven by the obesity epidemic. And that's really where we need to focus. And I showed you those slides earlier showing that when we look in our community in particular, particularly in Black women, it is a big problem. We really need to bring our weight down, try to get our BMI, our body mass index, closer to normal. And that will really help to improve the rates of high blood pressure and stroke in our communities. Simple things like improving the amount of exercise that we do every week. And you don't have to join, like a CrossFit gym and just go at it hard. I mean, even doing simple things like walking for 30 to 40 minutes a day around your neighborhood are often enough to reduce your body weight by, 5 to 10%. Sometimes we think that we have to just like do the most. You don't have to, be ready for the cover of Sports Illustrated. Sometimes your body's response from a health perspective will respond to very, very minor changes. But often it's the body weight, the obesity, and the diet. So if you look at all Americans, our diets are terrible. It's interesting. There is an emphasis on sodium, particularly in the Black community, and reducing the amount of sodium in our diet. Most Americans eat too much salt. And that is because the salt is embedded in our food. So there's salt in everything. If you eat any packaged food, Cheerios, bread, anything that is processed and packaged in a factory somewhere, it's got too much sodium in it. That's sort of become the American way. That's the way that they keep stuff on the shelf for longer. And we as Black Americans are not the only Americans who eat too much sodium. Most Americans eat too much sodium. If you eat anything outside of your house that you didn't cook yourself, it has too much sodium, period, point blank. What is, sort of clear is that Black Americans are more salt sensitive. So when we eat sodium, our blood pressure tends to go up more rapidly. It tends to go up more severely, and it takes us longer to get that sodium out of our system, and our blood pressure has a more severe response. And that's been known for a long time. That's the definition of salt-sensitive hypertension. And our bodies, for whatever reason, just don't process sodium as well. And so there are diets like the DASH diet, dietary approaches to stopping hypertension, that have been shown for a long time to really be very effective in Black Americans to helping to reduce high blood pressure. So if we can eliminate sodium from our diet, not just shaking salt on at the table, but also, get away from the fast food, the restaurant food, because all of that stuff has too much salt.
Thank you, thank you. We have a question where someone's asking, what are Hispanics doing differently that is resulting in a lower rate of heart disease?
Yeah. Nobody knows the answer to that question. Seriously, nobody knows the answer to that question. We call that the Hispanic Paradox in science. It's really interesting because when you look at, one of the things that we say in the literature is the reason why Black Americans have such high rates of heart disease is because we have such high rates of all the risk factors. But actually, the rates of the risk factors are pretty similar in Black and Hispanic Americans. Hispanic Americans are very overweight and obese, pretty physically inactive. They have pretty high rates of hypertension too, but their rates of heart disease are much, much lower. Again, the primary driver of heart disease in our community is really driven by the high blood pressure. But why Hispanic Americans seem to have this protective effect is really unclear. There's a couple of things that are sort of make it difficult for us to answer that question right now. We can only answer questions in science when we collect the appropriate data. When we collect data in science, we tend to group people together. So we call all Hispanics Hispanics. But when you look at Latinx from Mexico versus, Spain versus the Dominican, they're different, right? Like not all Hispanics are quote unquote the same, just like Asians. South Asians have a different rate of heart disease than East Asians, and people from China, from Japan. So we as scientists need to do a better job of classifying people. So that's one thing. There's also differences in terms of communities, right? So some of the things that we didn't talk about are, for example, the effects of racism in our community. There's been, I showed you for example, the effect of bias, but there was a study that came out last year showing the effect of racism in the experience of lifetime discrimination and how that impacts your risk of developing high blood pressure as a Black American. We can't get rid of our skin, right? We can't hide the fact that we're Black. I had a really interesting conversation yesterday with two Jewish men at Emory, and they were sort of saying to me, listen, like, I don't have to tell anyone that I'm Jewish. They just see me as a white male. So even though, of course, as a Jewish man, I have we as Jewish people have a similar history in terms of persecution as Black Americans, I don't necessarily have to reveal that aspect of myself as I don't want to, but as a Black American, you are always at risk for discrimination simply because of your skin color. And to a certain extent, the same thing can be said for Hispanic Americans, that oftentimes the experience of discrimination may not be as severe because if they have a more white appearance, they may not receive as much discrimination as we receive as Black Americans. And that type of nuance is not always gathered in the scientific literature. So as scientists, we need to do a better job of studying these things to try to define why Hispanic Americans seem to have this protection that we don't have as Black Americans. You know, again, when we try to understand why Black Americans are at such high risk, we haven't always been the ones defining the narrative and defining the science, and hopefully people like myself and other young Black scientists will change that as we continue to do this work and look at, you know, the impact of racism, the impact of neighborhood, the impact of other factors that weren't necessarily always studied on rates of disease.
Okay, thank you. We have about 4 more questions. We want to be respectful of everybody's time. One of them is an easy one. Is it possible to get a copy of your slide presentation?
Sure, I can send it to Arthur and he can.
Okay, I figured that would be an easy one. So the next one, what are the typical early physical warning signs of a looming stroke or heart attack?
So, there can be a couple of things. For a stroke, what you want to be aware of is any neurologic sensation that is abnormal. So that can be something as simple as a loss of an ability to move one side of the body. A stroke typically affects one side of the body different. So you might feel weakness in an arm or a leg, slurred speech, an inability to talk. And it might sort of happen for just a few minutes and then go away. I might sort of have like a stuttering pattern. But if you experience that, particularly if you have these different risk factors like age, older age, high blood pressure, diabetes, or, you know, strong family history of stroke, you want to take that seriously and call 911. Certainly if it happens and it persists, like, you know, it stays there for a couple of minutes, you definitely want to call 911. Same thing with a heart attack. The classic heart attack symptoms are chest pressure or pain. People often say it feels like someone, an elephant is sitting on my chest. But we have to remember that those typical symptoms were described in men. So in women, oftentimes the symptoms are atypical. Women will often get symptoms that are like a stomach upset, like indigestion. And that's why women are often sent away from the emergency room with just like a cocktail, like some Maalox, and told you're just having, you know, GERD, you're just having reflux, go home and you know, take this Maalox and you'll be fine. Or women are told you're just having anxiety or a panic attack because women's symptoms are more atypical. So women need to be aware of that. And that's why I say, know your body. There was a case recently that I read about of a Black man in his 50s who worked for the fire department in the Midwest and went to an emergency room 3 different times with what to me as a cardiologist sounded like very classic chest pain symptoms. He was having chest pressure. Oftentimes that chest pressure is associated with shortness of breath, sweating. Sometimes it'll go up to your jaw or down your left arm or your right arm. Sometimes it'll go into your back. Typical symptoms are that it happens when you're exercising or exerting yourself. So if like every time you go up the stairs or every time you're, you know, walking up a hill, you get that type of pressure. That is classic, we call angina, or classic chest pain symptoms. It doesn't have to be classic, right? If it's not classic, that doesn't mean that you're not having angina. But if it feels like that, the doctor should take you seriously. And if they're not, that's a problem. So in this young man's case, he went to the emergency room 3 different times, and each time they sent him away. And the 3rd time they sent him away, he dropped dead in the parking lot. And I was just really sad and flabbergasted because in my opinion, that's total medical malpractice. You know, that description of chest pain is textbook. Not everybody has a textbook description of their chest pain, but that is textbook chest pain. And if you have something like that, it should absolutely be taken seriously. And if for some reason you're in an emergency room where they're not taking it seriously, you need to tell them you're going to sue, in my opinion.
Yeah, I can relate to a lot of what you just said.
Well, I mean, the data clearly show that as Black Americans, we are more likely to be turned away. And I hate to say that because I am a physician and I am a member of the healthcare system, but my job is also to, be an advocate for members of my community. I'm a Black person first, so.
Absolutely. Absolutely. That was amazing. And I can relate to a lot of the things you said about shortness of breath and sweating and such and what it can lead to. Not exercise sweating, but the kind you're talking about, right? So someone would like to know your thoughts on using water fasting as a means to allow your body to reset, regenerate, regulate itself, and ultimately heal, reversing many of the risk factors we face.
When you say water fasting, are you talking about intermittent fasting, or maybe I can answer that question by just talking specifically about intermittent fasting. There's a lot of data on intermittent fasting, which is fasting for different periods of the day. I actually do intermittent fasting. I try to only eat between noon and like 7 p.m. if I can. And there's actually really good data on that. To show that it improves how our body processes food. It's supposed to improve memory and concentration. Over time, it actually reduces hunger. And it actually has a lot of great metabolic effects. So not everyone does well with it. I would talk to your doctor about it before you start. For example, if you're a diabetic and you're on insulin, that might not be the best plan for you because you don't necessarily want to start fasting. If you have to take insulin shots at prescribed intervals during the day, you can get into a lot of trouble and become hypoglycemic. But if you are someone who falls into that category, or you're not taking medicines at a certain time of day where you're likely to get, a low blood pressure, for example, fasting can actually be a very effective way of controlling weight. And there have been shown to be some very positive metabolic effects that can lead to not only weight loss, but also just sort of helping with improvements in concentration and improvements in what we call insulin resistance. Insulin resistance is what leads to diabetes over time. So helping to make the body more sensitive to the endogenous insulin and decreasing the risk for diabetes. So yes, I wouldn't recommend fasting for, days or weeks, but certainly, limiting your food intake to 10 a.m. to 7 p.m. or 12 p.m. to 7 p.m. There's data that can actually be very effective for certain people. But I would talk to your doctor first.
Yeah, he was talking about fasting water only for 10 to 21 days.
Oh, I don't know if I would. That's a very long time. I'm not sure that I would do that.
All right.
Intermittent fasting, I think, is okay.
I want to share this question, then I want to tell some people about what the 100 is going to do for those who logged in today. So a lot of people are turning to fad diets such as the keto diet, etc. What are, or do you have an opinion on such fad diets as it relates to heart health?
So what I'll say is that we don't have a lot of data, right? I'm a scientist, so I go by data. What we have is anecdote, which is not the same thing as data. So anecdote is my homeboy did the keto diet and he lost 20 pounds. That's anecdote. Data is we did a randomized trial and put 500 people on the keto diet. We put 500 people on a vegan diet, and we put 500 people on the Mediterranean diet, and we followed them for 8 months, and we saw what happened in terms of these effects. And we don't have a lot of data. Number one, diets are really difficult to follow for most people, regardless of whether you're in a clinical trial or you're just trying to do it in real life. Dieting is extremely difficult. Keto can work for an individual, but everybody's body is different. And that's what's so hard about weight loss, not only losing weight initially, but maintaining weight loss. So what works for one person may not work for you. So just because your husband or your wife or your homie lost weight with the keto diet doesn't necessarily mean that it's going to work for you. That being said, for some people, it does work. What you have to do is be very careful. You don't want to do keto diet where you're eating burgers with, cheese and other things. That's not good. That will increase your risk for cardiovascular disease. What you want to eat is healthy fats, avocados, olive oil, things that are sort of monounsaturated fat. So there's a way to, if you're going to do keto, you can do it in a relatively healthy way. So I would do this sort of under the guise of a nutritionist. The other thing that we don't know is how long to do it and how long it will be healthy. There have been some studies that have come out recently actually showing that it's not more effective than other types of weight loss. Unfortunately, I don't want to say unfortunately, I shouldn't say that. I'll say this from a patient perspective. When I say this, most patients are like, the diets that have been shown to be most effective are actually vegan diet, Mediterranean diet, which is lots of olive oil, lots of fish, and actually bariatric surgery. Of all the things that have the most effective and most durable effect on weight loss, is bariatric surgery. The barrier that we have to getting people bariatric surgery is insurance. But if you look at the data in terms of medical interventions for obesity versus diets, bariatric surgery far and away has the best and most durable results.
Okay. What I'd like to do, I was reading the questions that we have, and we're not going to get to all of them, but if one of the ladies would like to ask a question, every question I've asked so far comes from one of the guys, which is fine, but do any of the ladies have a direct question for Dr. Morris? And you don't have to put it in the chat. You can actually turn your mic on and say it if you have one. All right, hearing none.
I have one.
Oh, we got one.
I'm
Carol
sorry.
Charles out of DC.
How are you? Glad to see everyone. I want to just say thank you so much. Thank you for this opportunity to ask questions. This is dear to me. I lost my mom in 2018, and for months, she just kept saying, it's acid reflux. It's my chest. It's acid reflux. And I kept saying, no, mommy, that's not acid reflux. And one day I just said, it's angina. And I don't know. I really don't know because we didn't do the autopsy and all that other stuff. But I do know that she had shortness of breath. She couldn't walk too fast. She couldn't go. And my mom was fairly young. She passed at 67. And she was going through these episodes for at least 6 to 9 months. And how do you know it's not acid reflux? It's not. It's angina. Like, what's the difference? Why do we get this so confused?
Well, so thank you for sharing. And I'm sorry for your mother's loss. And this is something that's near and dear to my heart as well, because, again, the work that I do is really trying to increase awareness in our community, not only to look at rates of heart disease in Black Americans, but to make sure that Black women understand that this is our disease too. So a lot of what you said really sort of registers with me for a couple of reasons. Number one, as women, we tend to take care of everyone else. This is so true for Black women, but we're terrible at taking care of ourselves. I think maybe part of that is because of the messaging, because again, for decades and decades and decades, as physicians, maybe we sort of put out this message, again, that heart disease is a man's disease, and that women don't get heart disease perhaps until they're older because estrogen is protective and all these things. That's not true anymore. That is not true. What you see is that Black women in particular are getting heart disease, having heart attacks at much younger ages. And in fact, fatal heart attacks in their 40s, and sometimes even in their 30s. So this is not an old person's disease. This is not an old man's disease. This is a condition, particularly for Black women, that comes at younger ages. So we have to be aware of it. Why the symptoms are more atypical for women, nobody really totally understands that. So part of it is that when women are patients, we tend, for whatever reason, to sort of experience these atypical symptoms and say, oh, it's something else. I don't need to tell my doctor about it. And sometimes we wait to go in and see the doctor. But then when we do go in and see the doctor, we're often told it's your anxiety, boo-boo, or it's your GERD, go home and take this. And so there's a delay in the diagnosis. And
That
so
was the last thing. I'm sorry. She said GERD. I was
yeah,
like, what's that?
right. And so by the time we are diagnosed, we're sicker and the disease is more advanced. And that is more true for us as African-American women as compared to other groups, but it's actually true for all women as compared to men. Because if a man shows up in the emergency room complaining of chest pain, he goes straight back and he gets his EKG and he gets a stress test and he gets all these things. But if a woman shows up complaining of indigestion, again, she's more likely to be, given Maalox and sort of told that it's GERD. Part of that is us needing to increase awareness in the cardiology community and making sure that we understand that women have these atypical symptoms. So GERD tends to happen after you eat, right? It tends to happen with more spicy foods. It sometimes happens when people lay down at night. It's associated with belching, but it shouldn't necessarily be associated with shortness of breath. It shouldn't certainly be exertional, but sometimes you can't tell the difference between the two. And that's my job as a good physician, is to say, well, if we can't tell the difference, let me do a stress test. Let me do an EKG. Let me do the appropriate diagnostic workup to help me feel confident and you feel confident that we're dealing with just reflux and not something more serious like heart disease. So I definitely need you as a patient to come to me and tell me what your symptoms are. But I also, as a physician, need to listen to you and do the appropriate workup. So that's why, number one, I need all of you all to take your symptoms seriously. Know your body. If there's a change, take it seriously. I mean, most of us have sort of experienced reflux a time or two and, have eaten something that didn't agree with our body and can get a sense of what is indigestion and have access to Tums or something that will make indigestion go away. If this doesn't feel like indigestion, don't ignore what your body's telling you, particularly if it keeps happening over and over. Tell your doctor. But if you're going to see a doctor who's not listening to you, find a different doctor, because your doctor should be taking you seriously. And unfortunately, there are just too many cases of doctors who don't listen to patients, and the consequences are fatal.
I
Wow.
do want to say thank you for that. Thank you very much.
This has been great information, Dr. Morris. I'm going to officially thank you in just a second, but I want to share two things with the group. We were talking about tracking your weight and tracking your body mass index and blood pressure and such. So I also represent the 100 Black Men on the National Health and Wellness Committee, and there's an app called iHealth. I use it now every day. I have all sorts of gadgets around me, but you can go to that iHealth app and I have all the iHealth scales and blood pressure cuffs and things. So mine is linked and it just inputs the data, but you can manually input data on your blood pressure and your height and weight, which is going to track your body mass index and indicators, right? So that iHealth app is free. So we can encourage everybody, just go to your app store and get the iHealth app, and it's working great. I'm going to the doctor in the morning, and when they ask me, what has your blood pressure been for the last week? I'm gonna open my phone and tell them. I don't have to figure out writing it on a sheet of paper, right? And they'll have that information readily available. But also, I have this iHealth blood pressure monitor, right? So the 100 Black Men, Keith Dennis, you're gonna get the bill. We're going to raffle two of these off through the Health and Wellness Committee to the 41 people that were on here at some point tonight. It's only two. So you got 2 in a 41 chance. Well, actually 40, because I'm going to take me and Dr. Morris out. So you got a 2 in 39 chance of winning. But we're going to raffle those off so two people can begin to take the next step towards tracking their blood pressure and getting healthy. And Aunt Carrie, we're going to count you and not Kevin. He doesn't count. But again, I want to thank Dr. Morris for giving up part of her evening when she can be doing anything else. I know the long hours she works in the hospital, and whether it's research or doing clinical time. But I also want to thank you all, because there's any number of other things you could be doing this evening, but you came here with us, and we will continue to send you information. Again, next month, we're going to talk about the availability and accessibility of COVID-19 vaccines. And then we're also going to talk about mental health next month. But I want to thank everybody for coming. And again, thank you, Dr. Morris, for sharing your wisdom. You all have her email address. If we couldn't get to all of your questions, I'm sorry, but you can please email her directly and get those answers. But again, thank you, Dr. Morris. I so appreciate you.
Thank
We
you
all
for having me.
appreciate you. All right. Have a
Thank
great
you,
night,
everyone.
everybody.